And is going to talk on the outcomes of radical prostatectomy. Welcome.
Good morning. Prostate cancer is a nationwide public health problem, worldwide public health problem. We have about 13.6% of all new cases of cancer and 6.1% of cancer deaths per year throughout the world. The sub-Saharan African scenario, we have about 16.4 per 100,000 with a mortality of 13.4. Compare that with Japan, that has an incidence rate of 22.7 per 100,000 with a mortality of 5 per 100,000. I think the African scenario may be more. We could be having some underreporting. Having been an African or being of African ancestry is a risk factor. And the sub-Saharan African scenario, we have an east-west disparity where you have 10.7 to 38.1% cases reported in East Africa and 4.9 to 19.8% in West Africa, and then you have South Africa flats in between. And the total prostate cancer rates in Africa are similar to advanced stage disease in the US. The staging, we use the TNM classification of, just to simplify, stage 1 and 2 would be early prostate cancer, stage 3 is locally advanced, involving the seminal vesicles, and stage 4 is metastatic. This is just a summary. The Gleason score, of course, you look at the cells, and you look at two patterns, the primary and the secondary, and you look at the cells that look similar to the normal cell, and you give them a score of 1, and the one that is different from the cell, a score of 5, and then you look at the primary and the secondary picture, then you get the Gleason score. Radical prostatectomy was described by Walsh and Donker. Actually, Pet Donker showed Patrick Walsh. They dissected a cadaver of a young boy, and they were able to describe the nerves to the penis. And it's a gold standard in terms of radical prostate cancer, localized prostate cancer. We need to understand the crucial anatomy of the dorsal complex and the pelvic plexus, which is about 5 to 10 centimeters from the anal verge, and right the seminal vesicle will be right at the midpoint of the dorsal complex. If you look at the tip of the seminal vesicle. We also need to understand about the cavernous nerve and the pelvic fascia. External sphincter anatomy is crucial in this procedure, and we often aim at the trifecta ideal of oncologic success, adequate continence, and potency. The surgeries for radical prostatectomy, you can do it open, retropubic, that is what we do here. You can also do perineal prostatectomy, radical prostatectomy. Here in Africa, I think Sarimgwe in West Africa with IVU med, there's a training going on perineal prostatectomy, laparoscopic radical prostatectomy, and of course the robotic. This is, I'm not advertising for anybody. I thought this will be adequate. Just showing the cavernous nerve there, the dorsal complex there, the bladder, of course the prostatocycle junction, and striated sphincter there, and the apex of the prostate. When you're doing radical prostatectomy, ideally what you do is disconnect the prostate, deal with the dorsal complex, disconnect that, go around, saving the nerves, and then do the bladder neck dissection, and then you do a uretrovesical anastomosis. This is a specimen of a prostate that we removed last year. That's the apical area. Those are the seminal vesicles that we dissected. The vasa differential will be somewhere there. I think that was a tumor there. So if you're doing radical prostatectomy, I think the trifecta ideal of local control, oncologic control, and potency. That region of fear could be incontinence, and national interest may be ED. The continence preservation mechanism, of course, will start with careful ligation of the dorsal complex, dissection of the apex, and of course you want to avoid positive margins on your dissection. dissecting the apex, and you want to preserve the situated sphincter, and you know very well that the cavernosal nerves moving just posterior. You want a length of about 1.2 centimeters of the membranous urethra, and of course you want to save the nerves, and you do blood and preservation. This has been shown by many series not to be very useful in terms of continence, but of course very useful when it comes to quality of life and when you're talking about urethrovesicoanastomotic strictures. Just trying to show how we've modified the wash technique in terms of dissecting the apex of the prostate. That's the prostate there. As the apex, I just used a Foley catheter, and that is the sphincter. If you're normally what I would do is that I would dissect up to the apex and then use that curvature of the prostate. And the idea is to get a canoe-shaped urethra. You see there, if you do it that way, you have about 1.3 there centimeters. If you cut transversely, then you have about 0.8 centimeters. So I try to gain more length, in terms of diameter, and I hope that in that would help me in terms of urethrovesicoanastomotic strictures, which will be more common in Africans, and also help us in terms of getting a good length. Of course, the question is, are we having positive apical margins or not? We shall come to that. So the nerve sparing technique, of course, you have to understand about the fascia, about pelvic fascia, the lateral fascia, the prostatic and the levator fascia, and of course the regions of the nerve. We know that you can injure the nerve at the level of the pelvic plexus, posterolateral to the prostate, and of course posterior to the membranous urethra. We presented some series of 21 patients. Of course, we have a challenge here in terms of early prostate cancer. So these are cases that we did from 2009 to 2013 December. I do my own transrectal ultrasound guided biopsy, and I would normally recognize the cause as advised. And we stage through MRI and radionuclide bone scan. All my patients go through cardiac evaluation, and normally we do the Charlson comorbidity index. And patients with a comorbidity index over 7, I would be a bit hesitant to go on with the operation, and perhaps advise them to go on with radiotherapy. We do bowel preparation and group and cross-match 3 units. We take an informed consent, and we talk about the possible complications and pros and cons of surgery versus radiotherapy and the other treatment options available. We give them cefuroxime sodium at induction and continue 8 hours for 72 hours. We give DVT prophylaxis with a Clexane on the first post-op day to the 5th post-op day, and all our patients will go into theater with 10 stockings. We do anatomical radical prostatectomy with pelvic lymphadenectomy via fundus incision, and we also do a nerve sparing when possible. The patient biodata, we include the PSA, the clinical stage, the Gleason score, the pathological stage, and the complications recorded. We would normally remove the Foley catheter on the 21st day and follow up with a 3-monthly PSA, and then a PSA that is above 0.4 nanograms per ml. We consider that as biochemical progression. So what are the results? We had 21 patients. 20 were black and 1 was Caucasian. And all these were done in the private sector. And the age range was 48 to 71 years with an average of 60.5 years. The PSA range was 4.8 to 94.3 with an average PSA of 35 nanograms per ml. And that was the distribution of the PSA. Half of our patients had a PSA over 20, and the average Gleason score was 7, and we had an upgrading of about 30% comparing the biopsy specimen and the prostate specimen once we had taken it to after the radical prostatectomy, once we took it to the theater, to the lab. The pathological stage was T2 at 61% and T3 at 39%. We had a 4.8% seminoventricular invasion. All the nodes that we dissected were negative. 4 patients had positive margins. none at the apex, actually 2 were lateral, 1 at the bladder neck and 1 posterior. And the mean follow-up was 27 months. And these are the complications that we got. Erectile dysfunction, 24%. Those are the EUA. I got this from the EUA guidelines, 208, and that is the IUCD, the SIU-based International Association on Prostate Disease. And those are 24%, and those are the comparison. Incontinence, 10%. Erectile injury, 14%. Urological stricture, 4.8%. Lymphocyte, 4.8%. One patient had myocardial infarction 2 weeks after the surgery, and we transfused 10% of patients. One of the patients was actually on junior aspirin, and he never told us. And the majority of the patients, the HB, actually by half of the patients, the HB dropped by less than 2 grams per deciliter. The average hospital stay was 7 days. There was no wound sepsis, no bone mets, and no mortality. Patient satisfaction was 90%. Biochemical failure, 24%, with 4 actually being within 1 year and 1 after 3 years. And the PSA range has been between 0.56 and 3.58 for the ones with biochemical failure. And all these patients had a Gleason score over 7, and of course some of them were the ones that had positive margins. And 4 of them received external beam radiotherapy. 1 patient is on bicalutamide, and their PSAs are all below 0.04. Discussion. Of course, in our local scenario, the challenge is less plate presentation. There is lack of expertise. I think, being fair, we have about 30% of the urologists here doing radical prostatectomy, and 80% of these procedures actually happening in the private sector rather than in the public sector. HIV pandemic, of course, is an issue in terms of if you want to score your patient and if you're thinking about massive transfusion. We know that Africans form keloids, and we know that urethral strictures are common in Africans. Because of that, I think as we do more radical prostatectomy, we might get more cases of psychoanastomotic strictures. There are a few publications on radical prostatectomy in sub-Saharan Africa. I actually just got one in my search for this. And of course, there might be cases of underreporting. The mean age was 60.5 years. I did compare this with a paper by Emoa from Ghana. He had also done 20 cases, and his average age was that compared to the Jamaican, who are almost similar to us. The black Africans in South Africa is about that, and also the American mean age will be about 68 years. The average PSA, ours was that, compared to the Ghanaian of 16.12 and West Indies 10.1. Our Gleason score, we had an upgrading of 30, and this compared well with the literature in the INCD on prostate cancer. Positive margins, we had 19. The Ghanaians had 15, and West Indies about 15.5. And the 7 vascular invasion, we had 4.8. Ghanaians had 25 and 3.5 in the West Indies series. But the biochemical failure, our biochemical failure correlated with the high Gleason score and the high PSA and T3 disease and positive margins. But the biochemical failure in the Ghanaian was 5%, and yet you have about 25% 7 vascular invasion. I think that there was some disconnect, and maybe it's just a question of time. Again, looking at the complications, erectile dysfunction, the Ghanaian had 21%. I think looking at these 2 series, there could be that maybe in Africans, incontinence is not a big issue. And maybe because in both studies, the patients had a good age of about 60, maybe perhaps that's why we have good outcome in terms of erectile dysfunction. In our series, the erectile injury was high. And these were the first patients, actually. And initially, I used to put them on LHRH analogs, and this made the dissection quite difficult posteriorly. The other thing is that if you're doing your biopsies, if they're not laterally directed, then you end up with a tight posterior dissection. In our conclusion, prostate cancer cases are expected to rise in Kenya. Patient selection is important, and research and consensus and guidelines are important for sub-Saharan Africa. And I think we need to embark on teaching, learning, and consensus building. Thank you.
Thank you very much.